High blood pressure is one of the most common conditions managed in primary care. However, not all hypertension is primary or essential hypertension. As you become a nurse practitioner, it is critical to recognize when elevated blood pressure is a symptom of an underlying condition rather than the condition itself. Secondary hypertension refers to elevated blood pressure caused by an identifiable and often treatable underlying disorder. Although it accounts for a smaller percentage of overall hypertension cases, it is frequently under-recognized. Missing secondary hypertension can lead to years of ineffective treatment and progressive organ damage. This training will focus on when to suspect secondary hypertension and how to approach the initial evaluation. You should consider secondary hypertension when blood pressure is severe, resistant, or atypical. Resistant hypertension is defined as blood pressure that remains uncontrolled despite the use of 3 antihypertensive medications at appropriate doses, including a diuretic. Other red flags include onset before the age of 30, sudden worsening of previously controlled blood pressure, or hypertension associated with unexplained laboratory abnormalities. The first major category to consider is renal causes. Chronic kidney disease is one of the most common contributors to secondary hypertension. Reduced kidney function leads to sodium and fluid retention, increasing intravascular volume and blood pressure. Clues include elevated serum creatinine, abnormal estimated glomerular filtration rate, or abnormal urinalysis showing protein or blood. Renal artery stenosis is another important cause, particularly in patients with sudden onset hypertension, worsening kidney function after starting an angiotensin-converting enzyme inhibitor, or abdominal brutes. Endocrine disorders are another key category. Primary aldosteronism should be suspected in patients with hypertension and low potassium levels, especially if muscle weakness or fatigue is present. Excess aldosterone causes sodium retention and potassium loss, leading to volume expansion and persistent hypertension. Screening typically includes measurement of plasma aldosterone and renin levels. Thyroid disease can also contribute to secondary hypertension. Hyperthyroidism increases cardiac output and systolic blood pressure, while hypothyroidism increases diastolic blood pressure through increased vascular resistance. Subtle symptoms such as weight changes, temperature intolerance, or changes in heart rate should prompt thyroid testing. Pheochromocytoma, although rare, is a critical diagnosis not to miss. This catecholamine-secreting tumor causes episodic hypertension accompanied by headaches, palpitations, sweating, and anxiety. Blood pressure may be extremely labile. Evaluation includes measurement of plasma or urinary metanephrines. Another frequently overlooked cause is obstructive sleep apnea. Repeated nighttime hypoxia activates the sympathetic nervous system, leading to persistent hypertension. Patients may report loud snoring, daytime fatigue, or witnessed apneas. Treating sleep apnea often leads to significant blood pressure improvement. Medication and substance-related causes must always be reviewed. Nonsteroidal anti-inflammatory drugs, oral contraceptives, corticosteroids, stimulants, excessive alcohol intake, and certain supplements can all raise blood pressure. A thorough medication and lifestyle history is essential. The nurse practitioner's role is not to test for everything at once, but to use clinical clues to guide targeted evaluation. Effective management of secondary hypertension requires identifying and treating the root cause, not simply adding more medications. In summary, secondary hypertension should be suspected when blood pressure patterns do not follow the typical course. Early recognition improves control, reduces complications, and reflects advanced clinical judgment. To reinforce this topic, complete the companion quiz and case study available inside Nurse Learn. These exercises are designed to strengthen clinical reasoning and prepare you for both board exams and real-world patient care.